Okay, picture this. A young, otherwise healthy patient comes to you saying food keeps getting stuck in their chest. Now, your first thought is probably acid reflux, right? But what if it's something else entirely? Today, we're going to break down eosinophilic esophagitis, or EOE. This is a big one, a condition you've absolutely got to know for the wards, for clinic, and especially for your board exams. So here's our game plan. We'll start with a quick clinical primer, then get into how to spot the classic EOE patient. After that, we'll cover how to nail the diagnosis with a scope and biopsy, talk about the main treatments, drugs, diet, and dilation, and then wrap it all up with a super high-yield review for your exams. Let's do this.
All right, let's jump right in. What's the one clinical presentation, the one thing a patient can say that should make the EOE alarm bells start ringing in your head?
This right here. This is the classic scenario. A young patient, feeling fine otherwise, tells you they have dysphagia, that awful feeling of food just getting stuck. Now, it's so easy to just chalk this up to GERD and move on, but here's the thing you have to remember. This is a mechanical symptom. That one little clue should make you pause and think, wait a minute, maybe this is bigger than just acid reflux. You know, the whole story is pretty much right there in the name, eosinophilic esophagitis. This tells you we are not dealing with a simple plumbing issue or too much acid. No, this is a chronic, immune-mediated inflammatory disease. The best way to think about it? It's basically an allergic reaction happening inside the esophagus. And that mental shift right there is what changes everything about how we diagnose and treat it compared to standard GERD. Okay, so if that feeling of food getting stuck is our number one clue, what else can we find in the patient's history that helps us build a really strong case for EOE before we even think about picking up an endoscope? For your exams, pattern recognition is king. And EOE has a classic pattern. You're typically looking at a younger to middle-aged male. But the real giveaway, the thing that connects all the dots, it's a history of atopy. If your patient with dysphagia also tells you they have asthma or eczema or seasonal allergies, boom, your suspicion for EOE should go through the roof. Now, here's where it can get a little tricky, and honestly where a lot of people can miss the diagnosis. These patients will often complain about chest pain and heartburn, and it can sound exactly like GERD. The two things that really separate them are those mechanical symptoms we talked about, dysphagia and, even more seriously, food impaction. But the other huge clue, they'll tell you they've tried proton pump inhibitors, for their reflux, and they just didn't work at all. Okay, so your clinical suspicion is super high. You've got the dysphagia, you've got the history of allergies, you're pretty sure it's EOE. So how do you actually prove it? Well, to lock in this diagnosis, you need two key pieces of evidence, what you see with the endoscope and what the pathologist sees under the microscope. So when you're doing the endoscopy, you're on the hunt for some specific visual cues. You're looking for fixed rings that make the esophagus look like a trachea, or maybe some long linear furrows, or even little white plaques. But, and this is so important, even if the esophagus looks perfectly normal, if you suspect EOE clinically, you still have to take biopsies. Those visual findings are helpful, sure, but the biopsy is the only thing that gives you the definitive proof. This is it. This is the single most important number to burn into your brain for this condition. The diagnosis of EOE absolutely hinges on the pathologist finding a peak count of 15 or more eosinophils per high power field in those biopsies. That is the magic number. Less than that, and it's not EOE. It's as simple as that. So let's just put it all together. The official diagnosis is really just a three-part checklist. Number 1, the patient needs to have the right clinical symptoms, like dysphagia. Number 2, the biopsy has to show that magic number, 15 or more eosinophils per high power field. And number 3, you just have to make sure there aren't any other things that could be causing eosinophils in the esophagus. Now, let's talk about a clinical curveball. What happens if your patient has all the symptoms, they've got the eosinophils on biopsy, but then you put them on a high-dose PPI and they get completely better? This is a really fascinating group we call PPI-responsive esophageal eosinophilia. It's a super important distinction to make because almost half of these patients might not need any other treatment. It's still being debated whether this is just a type of EOE or its own separate thing, but you definitely need to have it on your radar. All right, diagnosis is confirmed. You know it's EOE, so now what? What's our game plan? Managing EOE is a little different. It's a multi-pronged strategy. So let's break down the tools we have in our toolkit. The absolute easiest way to remember the mainstays of EOE treatment is with a really simple mnemonic, the 3 Ds. We're talking about drugs, diet, and dilation.
Honestly, this framework is going to cover just about every patient you see.
Okay, so let's walk through our 3Ds. The first two, drugs and diet, are all about controlling that underlying allergic inflammation. We can start with PPIs, which kind of surprisingly work for up to half of patients. If that doesn't do the trick, we can move to topical steroids that the patient swallows to coat the esophagus, or even newer biologics. The other option is a special elimination diet to figure out the food triggers. Now that third D, dilation, is different. That's a mechanical fix. We use it when the inflammation has been there so long that it's caused scarring and strictures. Think of it this way. Dilation opens the pipe, but it doesn't put out the fire.
Okay, it's time to bring it all home. Let's lock in the absolute most high-yield, must-know facts for your exam on eosinophilic esophagitis. This is the stuff you gotta know.
If you only have time to remember one thing from all of this, make it this slide right here. Number 1, EOE is an immune-mediated disease, not just reflux. 2, the classic patient is a young guy with allergies and trouble swallowing. 3, diagnosis is symptoms plus more than 15 eosinophils on biopsy. 4, on scope, look for rings and furrows. And 5, management is the 3Ds, drugs, diet, dilation. If you can master these 5 points, you're golden.
So I want to leave you with one final thought, a question to chew on. If a patient has eosinophils in their esophagus, but they respond perfectly to a PPI, why does it even matter if we give them the formal diagnosis of EOE? Well, it matters a whole lot, because this is a chronic, progressive disease. If it's left unchecked, that inflammation can come back, and it can lead to permanent fibrosis and strictures. So making the right diagnosis from the get-go, it isn't just an academic exercise. It's about protecting our patients from serious, long-term complications down the road.